Here we're going to be discussing some of the clinically relevant topics in relationship to the cardiovascular system. So the first one is hypotension, and hypotension literally means the low blood pressure, regardless of what the cause of the hypotension was. And hypotension leads to the decrease in the amount of blood reaching the different organs, especially the ones that are, extremely of extreme vital importance, like the brain and the cardiac muscle. If that prolongs for a longer period of time, that means that these vital tissues are not going to be receiving enough oxygen, and that can lead to what is known as shock. And we'll talk about shock in the next slide. You'll find that the causes of hypotension are pretty much the same causes as shock. So the causes of hypotension are decrease in cardiac contractility, so the inability of the cardiac muscles to contract the blood, for example, during heart failure. Strong emotions, so being exposed to very exciting news or very saddening news, both of those can lead to massive vasodilation of the blood vessels, leading to severe hypotension. And then allergic reactions. Remember when we talked about allergies, we mentioned mast cells and how they have loads of histamine, and histamine is a vasodilator. So in allergic reactions, we have, if there's lots of vasodilators or lots of histamine released, that can lead to, again, massive vasodilation and low blood pressure. That takes us to the next one, which is shock, which again is severe hypotension, leading to now that the tissues and body organs aren't receiving enough oxygen, and that can lead to them being damaged. And there are three different kinds of shock depending on the cause of that hypotension. So there's hypovolemic shock, which means that decrease in blood volume, secondary to hemorrhage, that can lead to shock. Low resistance shock, which is that caused by the massive vasodilation or systemic vasodilation, whether that is due to strong emotions or due to allergies. Infections can also cause that. Cardiogenic shock, and that happens in heart attacks. Okay, where the heart muscles now are unable to perform its function, leading to severe hypotension to a point where the organs and tissue aren't getting enough oxygen. Now, this is the distribution of blood in the body, and I know we went over this several times, but I just wanted to show you the numbers here, where if we exercise, the skeletal muscles under rest are getting 20%. When we exercise, it'll get about 75% of our total blood volume. Compared to that, to what's going on in the kidneys and in the abdominal organs, where at rest, they are getting 20 and 25%, while during exercise, they get about 3% only. And that is due to these changes that happen in the cardiovascular system. So when we exercise, actually even before we exercise, the brain starts to prepare the body for these upcoming strenuous muscle activity. And it will give impulses, send more sympathetic impulses to the heart and to the veins and arterioles in the abdominal organs and in the kidneys. So remember, the increase in sympathetic output to the heart increases heart rate, increases cardiac output. Increase the sympathetic output to the veins is going to increase the venous return, which obviously translates into increase in cardiac output too. And then the sympathetic stimulation to the arterioles and the abdominal organs and kidneys means that these blood vessels are going to constrict, diverting that blood away from those organs towards the muscles. The brain would also decrease the parasympathetic output to the heart. All of these changes eventually lead to increased cardiac output and, again, vasoconstriction to the abdominal organs and kidneys. While on the other hand, when the muscles contract, there is an accumulation of, first off, there is an increased need in oxygen demand. Okay, so there's like that local hypoxia, and there's an increase of the production of carbon dioxide and other metabolic waste products. So these local chemical changes, as we've learned in this chapter, will lead to local dilation of the arterioles in the muscle, and that is going to increase the muscle blood flow. Now, when we compared an untrained heart to a trained heart, meaning the heart of an athlete, that trained individual, to the heart of an untrained person, okay, so somebody that is not athletic, you see that the trained individual, the trained heart, has a higher cardiac output due to a better stroke volume, and they could do the exact same work and even better, but at a lower heart rate. So even at rest, the trained heart has a higher cardiac output, and when we break it down into the heart rate and stroke volume, you can see that green trained heart has a lower heart rate compared to the non-trained, while on the other hand, it has a better stroke volume compared to the untrained heart, which means that the athletic heart is definitely a better equipped, it has more mitochondria, it is able to perform better contractions, stronger contractions, and overall perform better with a lower heart rate. So they have slower heart rates and larger stroke volumes. Now, hypertension, which unfortunately is a common thing to happen, it is a chronic increase in systemic blood pressure above 140, over 140 and 90 millimeters mercury. And again, the importance here, the stress here is on chronically increased. So a transient increase in hypertension is not really going to be labeled as a hypertensive patient. You want a patient that, comes in today, their blood pressure is high, and then a week later, again, the blood pressure is still high. That is how we label them. So sometimes patients come in, they're just stressed out, they're having a bad day, or they're just nervous about being in the office. We cannot just because of one measurement, just label them as hypertensive patients and start giving them medications. You want to confirm that with several readings. And hypertension is known as a silent killer because it really doesn't, a lot of the times patients don't even have any signs or symptoms, or they don't have symptoms, and it is a risk factor for developing atherosclerosis and eventually heart attacks. There are two different kinds of hypertension. There is primary hypertension, and that's the most common kind, and that usually develops due to age and the development of atherosclerosis. Secondary hypertension means that there's something else going on in the body that led to hypertension. So the most common cause would be hypertension that develops due to chronic renal failure. The primary hypertension are obesity. So these patients, if you find a patient that has some of these red flags, you want to, ask them before they become hypertensive. Remember, the aim is not to treat patients. The aim is to detect patients who are at risk for things and manage them before they get hypertensive. So obesity, diabetic patients, especially type 2, or the insulin resistant kind, chronic high salt intake, stress, smoking, excess intake of alcohol and caffeine, poor diet, low birth weight and not being breastfed as an infant. That can translate 50, 60 years down the road. That makes them at a higher risk of developing primary hypertension. And then genetic problems with the renin-angiotensin-aldosterone system, which we will go over in more detail when we get to the kidneys. Primary hypertension is usually managed by, asking the patient to kind of manage their diet, decrease salt intake, increase fresh fruits and vegetables, control their diabetes, exercise, telling them to, some lifestyle changes like stop smoking, decrease the amount of alcohol and caffeine consumption, having a healthier diet, and so on. Now, some of the contributing factors of secondary hypertension, remember that there's another problem that led to hypertension. Most of the time, it's damage to the kidneys, and we call that renal hypertension. Other times, it could be hypersecretions of different hormones like cortisol, aldosterone, and thyroxine hormone. And if you're not sure why, you want to go back and review these hormones and their functions from the endocrine system. The abnormal nighttime sleeping patterns and sleep apnea are also risk factors for developing hypertension. Sleep apnea is a patient that stops breathing during sleep. Secondary hypertension can be managed by medication, but even more importantly would be to identify what the cause is and try to manage that cause. Now, these are some common drugs that we use to treat chronic hypertension and how they act. I added on there a couple of the most common kinds of medications. You're not responsible for knowing their names, but I'm sure you've either encountered them or will in the future. So diuretics, those lead to increase of the excretion of sodium and water in urine, and that would obviously decrease the blood volume and decrease blood pressure. Beta-adrenergic receptor blockers, more commonly known as beta blockers. So let's step a little bit back what are the functions of beta receptors? Beta-adrenergic receptors of the heart lead to increased cardiac output and increased heart rate, which increases your blood pressure. So these beta blockers are going to block these receptors, which will lead to a decrease in cardiac output and decrease in blood pressure. The third kind are known as calcium channel blockers. Remember, calcium ions are important for smooth muscle contraction. Well, if you block these calcium ions, that would lead to vasodilation of the arterioles and decrease the decrease in the peripheral resistance, which decreases blood pressure. ACE inhibitors, or angiotensin converting enzyme inhibitors, those decrease angiotensin too. And again, we'll get more in detail about this when we get to the kidneys. I think we touched upon this in the endocrine system as well. So you should at this point have at least a good background on how this works. So angiotensin 2 leads to decrease in the amount of angiotensin 2 would lead to vasodilation, which decreases the peripheral resistance and decreases blood pressure. And ACE inhibitors also decrease the hormone aldosterone, and that leads to more loss of sodium and water in urine. Coronary artery disease is another common disease where there is an insufficient blood flow in the coronary arteries, which means that the myocardium isn't getting enough blood, and that is known as ischemia. This can result in MI, or a myocardial infarction, also known as a heart attack, where the myocardium is damaged. About 1.1 million Americans get a new or a recurrent heart attack, and about 40% of those are going to die because of that. The main cause of death is ventricular fibrillation, or VFib, where there is that total loss of connection between the atria and the ventricles, and then the ventricles are just firing up or contracting in a very, very high rate, which pretty much there is no real diastole or systole, and which pretty much means that there is no cardiac output. Okay, so that is a fatal condition. Unless these patients are helped with quick CPR and defibrillation, VFib can be fatal. In the next portion, we'll talk about hemostasis or blood clotting.